Good morning, good afternoon, good evening to everybody, and thank you all for joining this panel. I'm Anup Verma, an alum of IIT Roorkee, and on behalf of Penn IIT USA Board and over 50,000 members, I welcome you. COVID-19 has not only speeded up technological innovation in healthcare, but also exposed inequality in healthcare ecosystem, both within US and globally. In yesterday's address, Dr. Vivek Murthy touched on adoption of technology in healthcare. And many of you heard CEOs from FedEx and IBM. They also shared the focus on solving complex healthcare problems. Today, we have an illustrious panel of thought leaders to talk about facets of healthcare and how COVID-19 has impacted these. Our moderator will introduce the panel as we go, but as a board member of Penn IIT USA, I'm honored to welcome a very illustrious guest who are experts from healthcare innovation, health equity, and healthcare democratization. You will hear from our panel with Mr. Glenn Tullman, leading healthcare innovator, a fan of India and good friend of India. Glenn has just successfully completed the largest merger in digital health. It valued Livongo, the company he founded, at close to $20 billion. Dr. Meeta Goel, one of the leading researchers in health equity, did her fellowship at Harvard. She's a professor and practices at Northwestern, my other alma mater. Meeta will share insights into how recent COVID-19 related research is impacting healthcare experts' view of their discipline and patients. For a discussion on technologies like artificial intelligence and how these are causing disruption in healthcare, we have Dr. Rajni Natasan. She has spent her career focused on building disruptive technologies to transform patient care. She has led the design and deployment of AI-based technologies at both large hospital systems and at early stage companies. She's the Chief Medical Officer of Braid Health. Last but not the least, Dr. Sanjeev Arora. He's already known to us. Yesterday, he conducted the fireside chat with Dr. Vivek Murthy. He is director and founder of Project Echo. He's a distinguished and Regents Professor of Medicine with tenure in the Department of Internal Medicine at the University of New Mexico Health Sciences Center. Project Echo that he founded has expanded healthcare democratization with almost 200 hubs in USA and in over 40 countries. Dr. Arora was named the 2021 laureate for the Brock Prize in Education Innovation. Sanjeev has kindly agreed to moderate this panel. Now, with a virtual big hand, I invite our moderator, Dr. Sanjeev Arora, and the panel to open this panel discussion. Thank you.
Well, thank you, Anup. And what a great honor it is for me to moderate this panel of colleagues who, in their own right, have made such substantial contributions to the area of health and technology and of course, business, as you'll hear from Glenn. Amazing. So the focus of this panel, I'm going to try and present to you what the focus of the next hour and 15 minutes will be. We're going to ask this simple question that when cell phone technologies came into the world, they fundamentally transformed the life of a poor person. So imagine a fruit seller in India. Previously, he had no landline. He couldn't communicate with his supply chain. He didn't know which houses to go and knock on, who would be there, what fruit they wanted. And the inefficiency created was dramatically wasting half his time information seeking. Where could he get something from? What could he take to someone? And as cell phone comes along and immediately doubles his productivity, the man who irons your clothes in India, the same experience. But this technology has not resulted in the same change in the life of a poor man in the United States or in India in terms of health. So the question I'm posing to us, all of us, the panelists here, is what does it take for us to think through technology in healthcare in such a way that it has the same impact on the health of a poor person and produces equity there as it did in the field of economics. So with that, it's a great honor for me to introduce our first speaker. Dr. Rajni Natasan is a physician, also has done her an MBA, is a seasoned healthcare executive and thought leader in the use of AI and for disease detection, management, healthcare operations. Dr. Natasan brings deep C-suite expertise in finance, strategy, operations, clinical functions, and across med device, health tech companies. And she has really worked in conceptual design of FDA trials, commercializations, IPOs. She's the chief medical officer of Braid Health, which is leading strategy for venture-backed disruptive digital health company in its development and delivery of an AI-powered medical imaging diagnostic platform. Prior to that, she was a co-president and chief medical officer at QT Ultrasound, another multi-device device company. She's also a board-certified breast fellowship-trained radiologist, and she was on the faculty at MD Anderson Cancer Center, where she drove the community expansion and partnership, well published in the area. She began her career first on Wall Street at Lehman Brothers. And I really welcome you, Rajni, to this panel, and really looking forward to hear your perspectives.
Thank you, Sanjeev. Thank you for that kind introduction. It's a true pleasure to be here today with everyone. And going to your first question, Sanjeev, I think it's safe to say that we're in a very unique time, and that every person in every industry globally has been impacted by COVID. And I think that's center stage here at this conference, and probably here at this panel as well. And in healthcare, I think it's truly shaken the foundation of the industry. And so much so that we're asking ourselves questions now, how do we securely share data globally to every individual everywhere, especially everyone with a cell phone now? How do we ensure everyone gets the access to care that they need, no matter where they are, whether it's a rural area or an urban center? How do we prioritize who should be getting care? And is our healthcare industry optimally designed to really handle the future? And I think all of this is happening at a time contextually when we're seeing just tremendous innovation in technology across industries, healthcare, but also beyond. So think about that farmer, right? Being able to bank securely with end-to-end encryption on his cell phone, or AI-based systems that help in clinical decision support at institutions like Northwestern or MD Anderson, or even autonomous robots now making your coffee or delivering packages, right? So with the onset of COVID, we've seen ourselves really set up for a digital revolution in healthcare, and something that I think we've been on the cusp of for a long time. And we've seen the value of medical data sharing, cross-country collaboration. We're also seeing patients get more and more comfortable in this age of digital health, something that I know Glenn will speak about. And there's a shared understanding today of the fact that we are truly just one global community. Even beyond other epidemics we've seen, be it smallpox or polio, we're seeing COVID affect just about every single person on this planet. And all that being told, I think it's a very exciting time to be in this space. A time where we're not just seeing innovation, but equally, if not more important, we're seeing that strong desire and capability and yearning to leverage that innovation, and that the ground's really been fertilized for change. So I think in the next few years, we could really be seeing some of the most disruptive and impactful changes to healthcare. And all of that being said, I think it's really critical back to those individuals who don't have access, back to those individuals who may be in underserved areas where they may have just a touch of technology in their hands, be it a cell phone or some other device. I think it's important that as we innovate, that we are mindfully disruptive. And what I mean by that is, historically in healthcare, the trend has always been towards increasingly specialized technologies that come at a higher cost, are only accessible to a few. Moving forward, we need to look at the impact of those technologies and make sure that we're driving equity and truly serving this global patient population. And now we have the ability to do so with folks increasingly having cell phones. We have perhaps the most powerful piece of connected technology in the pockets of so many more people than we did even a decade ago. And that to me is opportunity. It's an opportunity to make a difference across the board.
Well, thank you, Rajni. Our next speaker is Glenn Tullman, founder and executive chairman, Livongo Health. He's also a managing partner at 7 Wire Ventures. Glenn is the founder and executive chairman and chief executive officer of the company he founded, Livongo, which is first at-scale consumer health digital company to truly empower people with chronic conditions to live better and healthier lives using data science. In its final year, Tullman led Livongo through the largest consumer digital health IPO in history, a secondary offering, a convertible debt offering that raised over $550 million, and the industry's largest merger to date between Livongo and Teladoc Health, valuing Livongo at $18.5 billion and beginning a new era of consumer-centric virtual care. He's a visionary leader and entrepreneur. Tullman previously ran 2 other public companies that changed the way healthcare is delivered. He was the chief executive officer of Allscripts. The company was the leading provider of electronic prescribing, practice management, and electronic health records. Glenn led Allscripts IPO and secondary offerings. Prior to Allscripts, he was the CEO and officer of Enterprise Systems, which he also took public and then sold to McKesson HBOC. Tullman is one of 2 founding partners at 7 Wire Ventures, one of the highest returning venture capital funds in Illinois. And he's the author of a book, On Our Terms, Empowering New Health Consumer, in which he proposes new solutions. He's dedicated to finding a cure for diabetes and other chronic conditions, and to keeping people healthy until these cures are found. He's a strong proponent of philanthropy. He was honored in 2019 with the Robert F. Kennedy Human Rights Ripple of Hope Award for his career focusing on improving the safety, empathy, and efficiency of our healthcare system. He also serves as chancellor to the International Board of the Juvenile Diabetes Research Foundation and as a board member of the American Diabetes Association. And he has 3 amazing children that inspire him every day. Over to you, Glenn.
Well, thank you for such a wonderful introduction, Sanjeev. And Rajna, thank you for your comments, how beautiful they were and important in terms of what we're going to talk about today. It's a real honor to be talking to this group because I've had a chance to work with so many graduates. And maybe just by way of background, you heard a lot about what I've done. Maybe the idea behind what I've done is important. So Livongo was a company really focused on how do we empower people with chronic conditions to live better and healthier lives. And it was started really from 2 different roots, if you will. One was my youngest son, Sam, was diagnosed with type 1 diabetes when he was 8 years old. And he's now 26, he's doing well. But his experience showed me how hard our health system, particularly in the US, makes it for people with chronic conditions to live healthier and better lives. And even if they want to, we put hurdle after hurdle in front of them. And we have a way of disempowering them rather than empowering them. So the idea behind Livongo was how do we empower people and how do we use technology to truly empower people? So we took what was then a very unique connected glucometer. Glucometer is what you use. You prick your finger and take a little drop of blood to check your blood sugar. And we put a cellular chip inside of that. And we created a whole experience around that. So I should admit that I'm a social anthropologist by training. I'll also tell this group in particular, my favorite country in the world is India. I've traveled there more than 25 times. And I fell in love with the country. But I also saw, interestingly, a similarity between health disparities across India, across the US. And I said, how could 2 great countries have the best of technology, have the best of science, and yet have areas that there are people without care. So I think of technology as really creating abundance. And we've seen this in so many areas. You know, we saw this years ago when Google, when I was growing up, and I'm showing my age, all the information was in libraries and maybe in encyclopedias, but they were always outdated. And then Google came around 24 hours a day, 7 days a week. It was available to anybody with a cell phone, anybody with access to a computer. Then Facebook connected us from a community standpoint. Now, we might argue whether it's good or bad, but we know it's powerful. We saw the power of technology for communities. And then, of course, Amazon came along and made commerce connected 24/7 and available. So you think about that. We had content, we had community, and we had commerce. And there's one last C, and that's care. And I always thought, what if we could make care available 24/7 anywhere in the world, to the access to the best experts? What if we could make testing strips free? We did that at Livongo. And so this idea of Livongo was we empowered people, we put them in charge of their care, we made everything they needed available 24/7. And that was really the idea behind it. And so I think what's next is, how do all of us start to use these powerful technologies to deliver better and more equitable benefits across the entire healthcare continuum? So that's really what I've been focused on in terms of using technology to improve business processes. And most recently, the last 3 companies, and the next one that's not yet announced, but it's coming, are all about how do we improve care and how do we use technology to put people back in charge of their care. How do we drive down the cost of care? And how do we bring this amazing science that we have, amazing data science, amazing behavioral science, and amazing doctors? How do we get all of that benefit shared to everyone? And I think Rajni had this beautiful comment. I won't repeat it exactly because I won't say it as eloquently as she did, but I think what the pandemic has shown us is that we're all one community when it comes to health. We can't have some people who prepare our food, deliver our food, who do our cleaning. They can't have a virus and then we feel immune to it. So we have to provide worldwide a basic level of care. And that's kind of my dream, my vision. So that's, I think, a good overview of Livongo and what we're doing and what I'm focused on.
Well, thank you, Glenn. And I hope our audience here is getting a preview of what you're going to hear in this panel discussion. And our next speaker is Meeta Goel, and she's going to talk about a very different issue of we don't want to leave half the world behind. Meeta Sanghvi Goel is an associate professor of medicine at the Feinberg School of Medicine at Northwestern University in the Division of General Internal Medicine and Geriatrics, a graduate of Beth Israel Deaconess Medical Center, where she served as chief resident, and of the combined Harvard General Medicine Fellowship program. Dr. Sanghvi Goel is a practicing internist with a long-standing commitment to improving care among diverse patient populations. In her role as an educator, she leads the Health Equity and Advocacy curriculum for the Feinberg School of Medicine and is the director of the dual MD-MPH program. As a researcher, she's had numerous projects integrating social determinants of health into the clinical setting. She's currently principal investigator for a Health Research Services Administration project, preparing the primary workforce to identify and address social needs in clinical practice. And welcome, Meeta. Over to you.
Thank you for that introduction. And it is really a pleasure to be a part of this conference, especially with my esteemed colleagues on this panel. And it's also an exciting time to think about the relationships between all of these areas that we are discussing. As has been alluded to, COVID-19 has highlighted a number of different inequities, and it has also really supercharged our understanding of the connectedness that we have between a variety of populations that perhaps we didn't think about before. What's interesting is many of these issues predate COVID-19. So if we think about cardiovascular disease and who is more likely to get it and pass away from it at a younger age, or diabetes, as Glenn had mentioned, who there are differences in who gets especially type 2 diabetes and who is able to control it versus not. These are all inequities that previously existed. And yet, what's different now? With COVID-19, we really thought about what this means within an infectious disease framework. It means that our individual health is directly tied to that of our neighbors and that of our communities. And that has really, I think, provided a foundation for revisiting what equity means and the importance of being able to address that in order to improve individual and population level health. So what's the role of technology in doing this? I think that as we've heard from our colleagues so far, there are a number of different places where technology can play a role. Oftentimes, technology has been used in settings that really only affect the top of the pyramid. So in urban settings, in academic medical settings, among those that have access to these tremendous organizations like Northwestern University. And it has also relied on those that have access to technology. So whether it is broadband access, whether it is smartphone technology, but it hasn't as well penetrated in areas that are rural or outside of these areas. So how can we think about what the full reach of technology can be? Because it is just a matter of time, hopefully, before we get there. And it's also important to think about how we think about technology. If we have a pure focus on technology and creating access and awareness of technology, will that get us far enough, or might that still leave us behind? Thinking about technology, and in my role as a primary care physician and in my role as a researcher and educator, I think about technology as an important adjunct to all the other tools that we have, that it builds and extends the clinical decision-making of an individual. It allows for communication that builds upon a foundation of trust that is there between a patient and their doctor. These are important ways of thinking about it. So when designing technology, understanding the place of it within the ecosystem of healthcare, both within the medical system and the public health, is a critical piece of the design of technology. So I think it has tremendous potential, but it also has tremendous pitfalls, as we've seen with AI. And I think Rajni is probably going to talk about this. There's tremendous potential there, but we've also seen that if within algorithms that are developed, there are learning systems that build in disparities. So our understanding based on income and risk, we have the potential to worsen or reinforce some of the inequities that already exist. It doesn't mean that AI is not going to work. It just means that with the design of it, if you think about who the populations are that benefit and perhaps are left behind from the beginning and continue to monitor that, it allows us to think about it and to be proactive about redesigning it to be better and to have a broader reach. So I think with that, I'd like to just sort of sound a note of caution. I think technology has tremendous potential, but I think that it requires a careful attention to equity and a continued monitoring around how it performs in different populations in order to fully reach not just the top of the pyramid, but the base as well.
Thank you, Meera. Thank you for that word of caution and being sort of a guiding light of how we need to develop this technology. So I'm going to tell you a little bit about myself. I'm a gastroenterologist by profession. I grew up in India and came to the United States in 1980. Like many of you, I went to Armed Forces Medical College in India, and I got a free medical education. And for all my life, I had a deep desire to give back to India in some way. I felt that there was an enormous debt on me. And the other thing that has always bothered me was, you know, when I look at the IIT people here, the CEO of FedEx, the CEO of IBM, the CEO of Google, the CEO of Microsoft, some of the most valuable companies in the world are Indians. And yet, I don't see the same progress being made by the classmates in India. And I often wonder, why is it? that India is not does not have the same major technology prowess, or in physicians, some of the best physicians in India, in the US, come from India. And I've always been troubled by this gap, and I wanted to put it out there as a challenge to all of you to think through what can we do to do better and give back more. So I want to tell you my story here. Being a gastroenterologist and a professor at the University of New Mexico, I was facing a problem. And the problem was hepatitis C. So it was 2001. I went into my clinic and there was a 43-year-old woman sitting in the room with two children, a 14-year-old boy and a 9-year-old girl. And I asked her, how can I help you? And she said, I have hepatitis C. Can you treat me? And I said, of course, that's my specialty. I'll do that. How long have you had it? And she said, I've had it for 8 years. So why didn't you come earlier for treatment? And she said, I live more than 200 miles away. I called your nurse and she said there was an 8-month wait to see you. And I would have to make 12 trips to see you while I was getting these weekly injections of interferon and ribavirin. And I had a 1-year-old child at that time, and I'm a single mother. There was no way I could come 12 times, take so much time off work. So I said, I'm not going to get treated. So I said, why did you come today? And she said, I'm having pain here in the right upper side of my abdomen. I did an ultrasound and found she had a cancer of her liver, which was really slightly smaller than a tennis ball. There was nothing I could do. It was too big for a liver transplant now. We could not resect it. It was too big. She had cirrhosis and she passed away 6 months later. And I asked myself, why did she die? When I had all the medicines and they were available and it was treatable and we've left these two children as orphans. And the answer was she died because the right knowledge didn't exist at the right place at the right time. And without that, it was impossible to get the right care at the right place at the right time. And the problem I was facing was there were 28,000 hepatitis C patients who had been diagnosed in New Mexico. Less than 1,500 had been treated. They were trying to come to see me. There was no way. I was working day and night. There was nothing I could do. And there were no specialists in rural area, and not a single primary care doctor was willing to give this chemotherapy-like regimen, as Meeta can probably attest. So what happened is I set up this model, which we call ECHO, Extension for Community Health Outcomes, with the mission that I wanted to get everybody in New Mexico treated with this chemotherapy regimen. How would I do that? And second, if I knew if I could do that, then I could basically treat anybody in the world for anything. And the model consists of 4 things. One, I would use technology to leverage the expertise, me, a gastroenterologist, a psychiatrist, and a pharmacist. Second was I would share best practices with primary care clinicians. Third was I would use case-based learning. And fourth, I would use technology to monitor outcomes. So in 2003, I set up the first ECHO clinic, where I went around the state of New Mexico and I set up 21 new centers of excellence for treating hepatitis C. 5 were in prisons, 16 were in rural clinics. Each was run by a primary care doctor. And I gave them my protocol for treating hepatitis C. And I said, hey guys, let's treat it together. I'll help you. They said, no, this is too dangerous. We can't do that. So I asked myself, I had shared my best practice with them, but they were not willing to do it. So I asked myself, how did you become an expert? So I went back to my fellowship days and I realized that when I did my fellowship in Boston and Massachusetts, I would see a patient, I would present to my professor. I would see another patient, present to my professor, another one professor. And after 2 years, they started calling me a gastroenterologist. I said, aha, I'm going to use this model to create new hepatitis C specialists in New Mexico. And we would use the internet to track outcomes. So in 2003, once a week, I would meet with all these 21 people on an interactive video conference, just like I'm meeting today with Glenn and Rajni and Meeta. And they would present patients to me and my team, one by one. And in every 2-hour session, we would co-manage 8 patients. And then I'd give them a 15-minute lecture. And I did this week after week after week. And 2 things happened. In 18 months, they were great experts. They had become specialists. Second, the wait in my clinic fell from 8 months to 2 weeks. And everybody in New Mexico now could get treatment. Tens of thousands of people got treated. And I realized now we had hit upon something. We started doing research and we started showing echo was producing joy of work, reducing professional isolation, improving professional satisfaction. And we published in the leading medical journal called the New England Journal of Medicine, a head-to-head study that they could do the same level of care as us. Now, the challenge at this time, of course, was that 6 billion people didn't have the right knowledge at the right place at the right time. It wasn't really a problem of 28,000 hepatitis C patients. In India, 1,100 people are dying today, every day, of TB. The medicine is free. The gene expert machines are everywhere to make the diagnosis free. But if you don't know how to use the machine, if you don't know how to prescribe it, bad luck. 1,800 children die every day all over the world of diarrhea when we know oral rehydration can fix the problem. So the next step for us was, how do we help 1 billion people by 2025? And mine is not a for-profit. I have a not. I run the Echo Institute at a state university. So what we said was, we would train any university in the world who wanted to replicate Echo for free. And we would give them our technology platform, which Zoom is a component. We have a repository of information. And we started training one university after the other. We now have 246 academic centers in the United States, every major academic center. Rajni MD Anderson is an Echo Hub. University of Chicago is an Echo Hub. Northwestern is an Echo Hub. UCSF, Stanford, Johns Hopkins, Yale, all of them. So we basically started replicating it, and they started rolling out Echo projects. And now we have Echo projects for 70 disease areas, learners in 165 countries. We have 1,100 networks operating like the one I talked about, hepatitis C. And this was my opportunity to give back to India. So we partnered with the government of India. Eric Wan, who's the CEO of Zoom, was helpful. He has given me an unlimited Zoom license for the world, which I can then give out sub-licenses to people around the world. And we developed a software where all these universities could share information, curricula, case presentations, etc. And as of 2019, we had 237,000 mentees all over the world. In the first 9 months of this year, we are experiencing exponential growth. We have had 940,000 mentees in these 165 countries, with 1,100 hubs operating out of 45 countries. And the value proposition we make to an organization is basically like this: that if you're interested in service, and usually these are governments or academic centers, we will give you our technology, we will give you a solution which can allow you to amplify yourself and have impact with speed, scale, and fidelity. And the value proposition is, we want to make them an offer that they cannot refuse, Godfather's terms, and that cannot refuse is based on 4 ideas. We are going to give you the platform for free. We will give you the training for free. And we will also give you the amplification mechanism, which is the Echo model. And lastly, you can use it for the purposes that you think are important for yours. So in Africa, it's for TB and HIV and so on and so forth. In India, for mental health and others. And we will not guide that. And we would give you an innovation which has now in 300 publications shown to be disruptive, that you can basically break the relationship of cost and benefit, that you can get a lot more benefit and a lot lower cost all at the same time to produce more equity in your area. So that's Echo. And I'm going to now turn over to questions for my colleagues. And so thank you once again for all of you for being a part of this panel, Meeta, Rajni, Glenn. And the first question I'm going to ask is to Glenn, but all of you will get a chance to comment. What is consumer-centric virtual care, and what will change with its arrival? Glenn?
Well, thank you. And Sanjeev, it's really amazing. I hadn't heard your whole story. What a wonderful service that you're providing across the world. And I think that speaks to what a few of the colleagues on the panel have spoken to, and that is technology is here. We aren't going to slow it down. So our goal ought to be, how can we use it effectively to make changes? And, you know, the one thing I know, maybe the secret of Livongo that we learned there was it's not about the technology. It's about the experience you create for the people using it. And, you know, my favorite quote in the world is from Arthur C. Clarke. And he says, technology perfectly applied is indistinguishable from magic. So remember, we were using these connected devices and we were monitoring people. I don't like that term because it seems like we're looking at it, but we were using data science and we knew if someone was dangerously high or dangerously low, their blood sugar. And so we would call them within 60 seconds and ask them a simple question. It wasn't, how can we help? Because that means we're in charge. We said, what do you need? And that meant they were in charge. And sometimes they would say nothing at all. Sometimes they would tell us. But one kind of fascinating thing, they would say, you called at exactly the right moment. And that was kind of like magic. But in fact, it wasn't. We knew what was happening in their body from continuous glucose monitors, from their own checking and the like. So that was a use of technology that actually empowered them, that provided them the care, and we could do it anywhere. The second rule that we used, if it was, and this really came from one of my sons, he was playing a video game, an RPG, a role-playing game, and I walked downstairs and I said, gosh, I want to be a good father and I want to learn to play the game. So I asked him a simple question. I said, do you have the instruction manual? And he looked up at me and he said, Dad, nothing smart has instructions anymore. You just use it. And we use that as a principle that we couldn't train the 1 million people who now access Livongo. We couldn't train them. We had to make it so intuitive that anyone could use it in any language. And that was another design principle we used. So you ask about what is this new kind of care that we think of as consumer-centric virtual care. So the idea there is really, this isn't about consumer digital health. You mentioned the fact that we took, the largest consumer digital health company public, and then we did a merger. But really, I hope 5 years from now, we're never talking about digital health. We're talking about health. And health uses every tool we have to meet people where they are and to make it easier for them to stay healthy. So we should use technology to reduce the barriers and reduce the cost. And as you said, the reason we did this merger, people said, well, why did you merge? Well, it gave us the opportunity to get even more scale. We were at 1 million people using our software every day to help them stay healthier. And we merged with a telehealth company that was in 50 countries that could offer what we do to millions of people and be one place to go to access whatever you need. And it could be rural, it could be inner city, it could be international. It shouldn't matter because that's what it was. So this was about not expanding digital health, but creating this idea of its virtual care. Sometimes that's hands-on from a physician. And the reality is, if you need to see a physician, and you need to talk to her, that's basically, there's nothing like it. On the other hand, we haven't leveraged the intelligence of our physician community, and we surely haven't paid them appropriately because we're using them for the wrong things. So virtual care is about putting together technology with the intelligence and empathy of our trained physicians, nurses, caregivers, and making that accessible to anybody in the world. And that's what we see as consumer-directed or consumer-centric virtual care. But the one last thing I'd say about it is it's directed not by a physician. It's not somebody waiting 8 months to get into your clinic. It's exactly what you did, which is so wonderful. You said, wait, I can use my intelligence and I can make it more broadly available, because this idea of us going to see you, we have to flip that to say, you're going to be available when I need you, exactly. And if that's the middle of the night, if I'm too poor to travel, then we'll bring it to you. And that's what we have to do. That's the magic.
Thank you, Glenn. Rajni, did you have a comment you'd like to make on this question?
Yeah, I think it's very interesting to hear Sanjeev, your experience with Echo, and also Glenn with talking about kind of breaking down barriers. And I can bring this a little bit to Braid Health and some of the work that we're doing, especially on the AI front, because our company actually started out operations in Southeast Asia, something that a lot of folks don't know. And we sought out to help with tuberculosis specifically. And in Indonesia, you might have one radiologist for thousands of people. And when folks are getting screened for TB, you can envision that someone gets a chest X-ray somewhere on some device, and there's a courier on a scooter, and this is a true story, who goes to all of those different X-ray devices and picks up a CD. Now he has a backpack full of CDs, and he takes that backpack to the radiologist, who may be miles and miles away. Mm-hmm. And those screening studies for tuberculosis get interpreted. The radiologist reads over 1,000 a day. So going very quickly, far past the pace to maintain good accuracy, right? Because there's a need. And the patients get the diagnosis months later. So envision you're screening for a highly communicable disease without the resources to make it happen, using media formats that I can't find a laptop with a CD drive right in my house, right? I mean, it's that obsolete, and you can see all of the issues there. Right across the pond in Singapore, they have more radiologists per patient, and it's right next door. So imagine breaking down the barriers, the institutional walls, the technology walls, where we can actually share resources in a smart manner, right? And compare that with maybe an AI algorithm that has a really 99.9% efficacy for screening for tuberculosis, where that patient can get the diagnosis right away and say, you are 99.9% likely to have tuberculosis. You have a cavitated lung nodule. You pair that with the fever you had yesterday and night sweats. You should stay home and start treatment. So you pair those two things. And even in this country, the parallel to the United States is very high. So you think about access to care in some of the very underserved or rural areas of our country, even in urban areas, right? We have folks that don't have access to care. And why is it that a patient with a cancer diagnosis in Montana has to physically travel to Sloan Kettering, to Mayo Clinic, to MD Anderson to get the care, to participate in the cutting edge trial? We have the technology today to make this happen, where technology can break down those institutional four walls and allow the permeation of all of that expertise. And that's the kind of data transfer and collaboration that we're working on at Braid Health, which is no matter where you are, no matter who you are, in a one click, in a way just that like you share a picture of your baby with grandparents, right? Or you share a text with somebody. In the same manner, your full stack of imaging in full fidelity should be able to get to any provider you want to gain that expertise. And so I think a lot of the future of care is really eliminating those barriers and allowing information to flow, and reducing this kind of the siloed access that we have here, let alone around the world.
Thank you, Rajni. Meeta?
I think what is really fantastic to hear is there are a couple of critical pieces of advice, I think, that everyone has beautifully displayed. So Sanjeev, talking about building capacity in communities. So making sure that expertise is not just in one area, that there are ways of building local capacity in ways that are incredibly, that can be replicated and spread. So that's a really critical piece when we think about the equity and technology. Glenn, incredibly important piece about user-centered design. And that can take on the form of usability testing, right? So at the most basic form, one of the initial papers that I'd written was one of the first that looked at disparities in access and use of patient portal technology, because there was this belief that if patients have access to their own health information, everything from notes to their radiologic studies to lab studies, it should move with the individual patient. And so patient portals were the first foray into trying to make some of this happen. It turned out some patients love it and will use it, but really not everyone. And we went a little further in trying to understand why that is. It was really along the lines in the US that we would have originally thought or hypothesized. It was along the lines of race, ethnicity, it was along the lines of age, it was along the lines of insurance status, income. Well, you would think that maybe it's because they didn't have access to it, or maybe they didn't know how to use it. It turns out that was a small piece of it. But when we actually asked why, it was a really critical piece. Part of it was usability, so that was important. But in thinking of user-centered design, it was so many patients would say, well, I didn't think that this was going to be a benefit to me. I didn't know that I could use it this way. You know, I'm actually worried that someone is going to get a hold of my information and use it against me. So there are concerns around privacy. And we saw this in another study that we did when we looked at patients with congestive heart failure, a condition that can lead to repeated hospitalizations. And we said, you know what? We should be able to monitor this remotely. Let's give everyone a smartphone. It's going to track their activity level. They can log their symptoms. We can look at it in real time and we can give them a call. It turns out patients did not want us knowing how much physical activity they were actually doing, because it exposes all those parts that are incredibly uncomfortable, where we have a belief as an individual that we are doing the right thing, and we're concerned about maybe that being unearthed and shown and shared. So it was important to think within user-centered design about, you know, is it just about the usability and being able to access the technology and use it, or is it about my perception about the benefit, the risk of that technology, my prior experiences with using something like this? So really important to think a little bit about all of that when designing the technology for equity. So again, important points from everyone that I just wanted to amplify.
Thank you, Meeta. I'm going to go to another question, and that is, you know, we are completely surrounded by massive speed of technological adoption. So much so that it's difficult to keep up, even for some of us who are interested in technology. And yet, the adoption of technology in healthcare has been extraordinarily slow. Let me give you an example, which has affected Meeta, Rajni, and me personally. And now, Glenn, you're in the middle of it, having sold out to Teladoc. That before COVID-19 came along, telemedicine, that is a specialist seeing a patient remotely over a camera like Teladoc does, has been around for more than 30 years. The latest data, if you take from February of 2020, less than 0.5% of all the visits in the United States were occurring on telemedicine. Everyone else was adopting technology like crazy, but healthcare sector just wasn't coming to the table. So what's the problem? Why have we been so slow in adopting it? What incentives should be put in place to speed the adoption? And perhaps we'll go around in the same sequence that we did the last time. Glenn, you first, then Rajni, and then Meeta. Go ahead, Glenn.
Well, obviously it's very, very relevant given I now sit on the board of Teladoc. So, you know, what I would tell you is, and I was going to ask the question, so what's taking so long because we know what we should do. And I think fundamentally, we know it's not a problem of technology anymore. It's really a problem of leadership. It's also a problem of reimbursement and the way that our systems are structured. Interestingly, though, you know, normally we would blame the US system, but we see this all around the world. So, you know, I have to say that there's probably ample blame to go along and to go around. You know, the numbers are pre-COVID, we had about 3 to 5% utilization of telehealth around throughout the US. And post-COVID, it went up to, of course, 80 to 90%. In some cases, it was all you could get. And now it's settling in, and we think it will be settling in between 30 and 45% of the number of telehealth visits. Part of that will depend on reimbursement. You know, that said, if you think about that, 3 to 5% to 30 to 50%. And I think what we've demonstrated is that if the system needs to change, you can get a 10x change, which we believe would have taken 4 to 5 years. You can do that in 3 months. Now, sadly, and maybe this is one of the few good lessons that we'll learn from COVID. We know about the tragic loss of life. We know about the economic impacts. I think we're learning about the mental health impacts, but I think we haven't focused on what could be positive. That is, if healthcare gets accelerated, the kinds of programs that Sanjeev, you've talked about and you've led, if we could accelerate that around the world, that would be a positive of COVID. If we could accelerate education to turn it into appropriate digital education, not our kids sitting in our living rooms getting it. And there's an equity issue there too, because we know that trying to have 2 or 3 kids do Zoom at home, even if you have 3 computers, and even if then you have to have the bandwidth, and it just doesn't work. But we have demonstrated that we can provide high school, college, and even post university advanced degree education through this kind of format. So I guess what I'd say is, I think it's now for all of our healthcare establishment to stand up and say, this has demonstrated that we can use technology, use it appropriately, and deploy it in ways that truly accelerate these advances that we've seen in healthcare. And also we have to do what Mita suggested. When we do that, we also have to say, well, if it's available on a phone, yeah, today a lot of people have a phone, but is it a phone equipped? And does the phone have the bandwidth? And what does it cost? And so we have to think through the impact of this technology, but it does hold this promise for abundance in healthcare. And I think we can do a much, much better job. Like the example that Rajni gave, it's a beautiful example how we could use AI to get a 10x benefit. And we still need every doctor, and we can pay her or pay him as much as we need to. It's actually not less, it's more. That's what we can create, but we need the leadership now. That's my position.
Thank you. So I want to just make one comment about education. When we were doing the ECHO project, and as I mentioned, we set up 1,100 networks, 943,000 working, and we found that each doctor we were training around the world was helping almost 1,000 patients with that knowledge. That we were having a huge impact on health, but there was a bigger problem going on, and that is the children in these communities were not getting a good education because they were living in rural areas and there was no good teacher there. So we started applying ECHO for education, where the mentees were not physicians, but they were actually school teachers. And they were being taught, we taught them how to do virtual classrooms with Zoom, and did it in India, and so on and so forth, and how to do reduce social isolation, and social and emotional learning, and many, many things. And we found that actually a good way for us to really work on health was to work on education. Because when we look at research, what we find is that one of the biggest predictor for health is the educational status of a child. It is actually a bigger predictor than socioeconomic status. That is, if you're educated and you're poor, you still have a lot better health than you're non-educated and you're poor. So I think that the point you're making about the use of technology in education, to me, is a great learning I had from implementing the ECHO project around the world. And I will give a call out to anyone in India or in the United States who has who has a not-for-profit or a government entity who wants to adopt at least the ECHO model. The entire services, the platform, our training is free, and we would be happy to partner with you and give you that to fulfill your mission. And please reach out to me if that would be of interest to you. But Rajni, back to you, the question, why is healthcare technology adoption so slow, and what changes? Glenn talked about leadership. But I'm also going to put a blame a little bit on us as physicians, Rajni. As physicians, we have sometimes resisted the ability of technology to come in. I would love to partner with you to take your TB technology all over India today. But aside from that, what is it really that is the problem? Why are we as physicians not jumping right in? Why are we putting sometimes our interest in between the patient's interest and what is obvious, as you talked about, a computer reading that X-ray? Of course, the radiologist won't get paid when that happens, right? But how can we do that? What should we do?
Yeah, I think it's a really fascinating topic, Sanjeev, and I think healthcare is a laggard. When we look at Jeffrey Moore's chasm model, healthcare is definitely a laggard, and I think there are a few main drivers for that. One is that the risks are high, right? It's life or death implications, and any integration of technology, you have to understand that the consequence is an impact on human health, and that's a big deal, and is a direct impact. And I think secondly, I think it's a complicated field from a regulatory standpoint, right? The FDA is evolving almost every day with how to deal with some of these new technologies, from AI to ML. How do we allow for algorithms to boost what the providers are doing, let alone ultimately maybe even replaced, right? We're not there today necessarily, but there's a way we may be. And third, I think the development costs are so high, the entry costs are so high. There's a focus on ROI, and I think overall the investment costs are so high that the deployment can be expensive. And so I think we don't always talk about deployment costs and training costs. So we talk about patient education. There's a physician education component every time we change the processes and the workflows that they work in. And we talk as physicians. Atul Gawande talks a lot about muscle memory and patterns, and there's a reason. As a radiologist, when I look at a chest X-ray, I look at the same things in the same order every single time. And so I don't miss anything. I don't miss any of the diagnoses, the corners of the images. And it's that same workflow pattern recognition. When we change a main process, which is usually a new technology, it takes time. And we don't always quantify the effect of that. And third, I think, or fourth now, I think it's a structurally complex industry. We have so many different stakeholders, patients, doctors, health systems, payers. It's tough to navigate all of those at the same time, and everybody has competing interests. They're not always aligned, and we need to do a better job of aligning interests there. And I think we've changed our reimbursement models from fee for service to kind of capitated, bundled payments. And I think we've seen the effects of technology there, where everybody is on the same page. Incentives are aligned to reduce the cost and improve the outcomes for, let's say, a heart failure patient. So we're seeing that change and how technology comes in very intelligently. But you're right, Sanjeev. I think we have not thought about technology innovation on a grand scale. And I'll give you an example that I have. I think we're at in an inflection point, especially with COVID. But we've had the ability for years now to get millions of people live streaming securely into a Beyonce concert, right? I mean, let's think about the amount of technology that goes into that experience for 3 hours, right? From around the world. And yet to transfer medical data for a cancer patient from a community hospital to a center where they may have a clinical trial takes 10 to 14 days. I mean, if you think about that, and time is health in cancer, right? The quicker you start management, the better that outcome for that patient. So I think we're catching up now. And I think we're realizing, especially in the setting of the pandemic, a fire has been lit to a certain degree, where every single day in this pandemic, lives are being lost. And to the extent that we accelerate, I think there's been a huge realization across all of the stakeholders I mentioned that we need to adopt technology safely, but quickly, in a way that's never been done before.
Yeah. Rajni, if I can just jump in, though, I think that's why I believe it comes back to this issue of leadership. And we have the technology, and I think, and Sanjeev, thank you for bringing up the physician issue. I wasn't going to do it. I'm not a physician, even though my mother always wanted me. She said two things: could you just be a physician, and could you just stay at one company and have a stable career instead of continually moving to all these new young companies? But I failed on both. But I do think that we're at the point where we need everyone to come together and say, we have to do these. These technologies exist, they're here today, and we just haven't had the leadership. And I also don't think that we can hide behind it's just about economics, because if you're seeing 1,000 patients and you only make, a lower amount, but it's 1,000 because now you don't have to see everyone, you can focus on the ones who have more challenges, you can get paid the same amount. But I think we have to demand more from our healthcare systems and from our leaders of those systems to say there are certain things we just have to do. And people in the diabetes area in particular, people are taking this into their own hands. There's a whole bunch of do-it-yourself solutions now that have a full, what we call an artificial pancreas, essentially looping together. They're called loop systems that tie a pump to a continuous glucose monitor. People have written the software and we're ahead of companies. And now the government is trying to catch up because people are saying, I'm not waiting any longer. We have to take control of this. And I think we have to replicate that across the system. And I think we can't say, we want to be safe. And one of my colleagues and partners, Hemant Taneja, wrote an article in the Harvard Business Review called "The Era of Move Quickly and Break Things is Over." And what he was talking about is Mark Zuckerberg said, in Silicon Valley, we move fast and break things, and that's how we innovate. And he was pointing out in healthcare, you can't do that. You need a higher standard. But that standard doesn't have to be a slower standard. And I think, and it's a wonderful article if you haven't read it. But again, I love what you're saying. And I think we have to push everyone in the system to say, we know we can do better. Now we have the impetus, which is a pandemic. Let's use that to springboard and say we demand the same kind of better care across the system.
I think I want to make one point though, that our listeners today are industry leaders. And sometimes you find that it is hard for people to act against their economic self-interest. And sometimes it can happen that the medical profession can land itself in a place where their economic self-interest is not perfectly aligned with what may be perfectly in the best interest of patients. And when that happens, some external forces coming in can actually play an important role. An industry that actually fundamentally pays for healthcare also has a role. So there are it's the medical profession, it's the leadership as you talked about, and it's industry making a call for, because this is tragic that I'm in Vietnam, I can go to a machine, put in a card, and I get all my bank accounts and everything. I can go to the internet, I can make trades in my Fidelity account from Vietnam, but I cannot get the information on my patient who was seen in the emergency room 2 miles away from me yesterday, and they did 20 tests on him, including a CT scan. I have no idea what they have. And Meeta, I would like you to comment on this, but before that, our sponsor, Ron Gupta, I want to welcome him, because I know he and Anoop envisioned this session, which we are so enjoying. Ron, over to you.
Thank you. Thank you. I'm enjoying this session. I'm obviously not participating in all of it, but a fantastic discussion. I wanted to just make a couple of comments in 30 seconds or so. First of all, I apologize for not having Dr. Murthy in your panel. The Biden transition team called us a few days ago that Vivek Murthy's availability on these 2 days may be very difficult, and he may be called away any second, and that Vivek did not want to miss the opportunity to speaking to us, so he wanted to pre-record. And we did that with Sanjeev's help. Sanjeev, thank you very much. And I think the presentation, I hope many of you listened to it, was absolutely superb. People were really impressed with his humility and his talk about the family values, and also that he lives in a house at the moment where 4 generations of his family are living at the moment. And his dad called me last night, and he said the whole of his family, all 4 generations, are so proud of what Vivek said. And so I want to thank Sanjeev for that. And lastly, I want to thank all of you, Glenn, you, Rajni, Meeta, Sanjeev, of course, and Anup for arranging it. Thank you all very, very much. And hopefully, we'll have another panel similar to this another time. Thank you, Sanjeev.
Thank you, Ron. Thank you for this great opportunity to talk to people whom we admire so much, IIT graduates. So, Meeta, let's go back to this elephant under the table, okay? We have to crack this elephant here. That is, why are we in healthcare not adopting technology at a faster pace when it's obviously the right thing to do, when Rajni's innovation can help 1,000 times more patients and prevent deaths? And
absolutely, it's a pain point, isn't it, when you can see solutions available and the tremendous impact that these solutions, these technology solutions have for linkages, delivering care with higher fidelity, improving clinical decision making, reaching more people. So what is the problem? And I would say that taking in what Glenn and Rajni have said, it is really about aligning incentives and making it easy to do the right thing. I'm a primary care physician, and I can tell you every little tweak that happens with technology, I acutely feel the pain in my bones. I now spend over 2 hours documenting information and responding to technology after my 4-hour clinical session is concluded. That is not sustainable. And if we think about this, we have to think about the benefits, what the focus needs to be, and where some of the pitfalls happen as well. So largely, if we have a system that is about documentation and billing, then we may have challenges with having widespread adoption because we're not aligning the incentives with the clinicians nor with the patients. But if, as you're talking about, Sanjeev, with the technologies that you've created, you are building capacity, you are increasing the benefit to those providers that are participating, they are seeing more patients, all of the incentives are aligned. Glenn, with your user-centric design that allows patients to have more autonomy over their health in a way that integrates into their lifestyle for type 1 diabetes, so that we don't have to go through quite as much about here are your glucose monitoring goals, here's how you need to eat, here's how you need to take your insulin, but you are creating an artificial pancreas that does this thinking and integrates into your health and into your daily lives. We have then aligned all of the incentives for an individual. And Rajni, for you, the work that you're doing also aligns incentives. It says that we know that there are individuals with expertise and bandwidth, and we have distinct need over here in a different country. If we can align the incentives for being able to say we have need with capacity, then we're really going to get much more traction. I feel like right now, that is not the case. Technology is being implemented in a piecemeal fashion in a number of different settings for a number of different purposes. And as a result, on the ground, patients, clinicians feel the pain just as much, if not more, than the potential benefit.
Thank you, Meeta. I don't know the full name of this questioner, but it's MJ from Toronto who's asking a question. So I want to essentially broaden his question. His question is, what is the effect of lack of political will in slowing down these great e-medicine or AI technologies in the US? And I want to add just one more phrase to it. It's not just those technologies, and it's not just lack of political will. I think what you all are teaching, all of us, all three of you are teaching, that the time is right for a full transformation of healthcare, a technological transformation of healthcare, so that we can get better healthcare for everyone. So the right knowledge is there at the right place at the right time, for it's culturally appropriate. It's got the right language in there. It it assesses the need of the person rather than what we think, and all of those things, and uses artificial intelligence to anticipate need, all of that. But let's go back to the question: what is the effect of lack of political will? How are we going to do this? And what is how can we all play this role? And I think we only have 3 minutes left, so each of you can take less than a minute to talk about this question. Okay, Meeta, why don't you start?
Sure. I think rather than thinking about what the problem is, I think if we talk about the solution, one of the key things we can do is create multi-sector partnerships. As you can see from this panel itself, there is tremendous expertise and perspective to be brought. If we think about the COVID vaccine, there was a partnership in the US between the government and individual pharma that kickstarted Operation Warp Speed. The military is involved with production capacity. You've heard from FedEx how they are going to be involved in refrigerated airplanes in order to improve transportation and delivery of it. I think about it from the community perspective. Vaccines are incredibly complicated. You can present them and people will say no. So having community-based organizations and partnerships on the ground are another critical piece. So I think the solution really lies in creating multi-sector partnerships in order to highlight the benefits and be able to address any of the challenges up front.
Thank you. Rajni, for Glenn and you, focus on a more limited question. What can our audience do to help this situation? Less than a minute each, please.
Yeah, I think piggybacking on Meeta's response, I will briefly say that I completely agree on collaboration being the key and getting everybody on board with the change. And I think a piece of that as well is education, right? A lot of folks don't understand some of the new technologies that are coming out. They're scary, they're different. Are they going to replace my physician? And I think it's really important to get education around any new technology, and that's a very key piece to the puzzle. But back to your question, Sanjeev, your question specifically, can you repeat?
Yeah, I want you to tell them, what can the IIT listeners do to help this situation?
I have a lot of respect for the IIT listeners here on this call. I myself am not an alum, but both of my parents are. So it's just a privilege to be here today. And I know the scale and the expertise of the folks that are listening here. And I encourage anyone who is interested in making an impact on healthcare in a global sense I encourage them to get in touch. I would love to have a conversation, and I would love to partner with anybody interested in partnering. I think it's a fortunate time to be here if you're in this panel interested in healthcare and coming out of a background like IIT. I think the world is your oyster if you want to make a change.
Glenn, less than a minute.
Yes, and I'll conclude really quickly. One, focusing on what Rajni just said, no stronger tech community in the world than the one we're talking to, IIT alumni. And so focus on healthcare. That's where we need it. Number one. Number two, trust science, trust technology, monitor it, of course, be intelligent, of course, but we have to trust it. Number three, I know I only speak for some of the people in the US, but I think we have brand new leadership, and in particular, Vivek, excited about him being involved. In the last Democratic administration, Anish Chopra, the first chief technology officer in the White House, a good friend of mine. I know he's going to be involved as well. So we're going to have great leadership. We have the ability to do this. And so I would just encourage you, if you're involved, do things that make a difference and push, push, push.
Thank you. And I want to take this opportunity to thank the panelists. It was so amazing to get to know you and your work. And I would love to collaborate with each one of you if given the opportunity. And of course, everyone in the audience too, thank you for listening, and back to you, Anup.
Thank you so much. I have been in technology innovation for quite some time, and entrepreneur, ran some private equity-led company and stuff like that. But for the last about 6-7 years, I've been in healthcare. And every day interacting with people like yourself is such an humbling experience, and understanding the magnitude of the impact, the future, the things that you do is immense respect for all of you. Some of the comments that have been there, we try to cover all the questions from the audience. Some of the comments are just so full of gratitude for all that you have shared. fantastic vision, great insights, and good to see engineers and doctors working together. So once again, Glenn, Meeta, Rajni, Sanjeev, we all thank you for your insights and the vision and some of the collaboration that you described. All of you were excellent. PenIT US is grateful to you. And like you said, we hope that these will inspire IT community for many more innovations and breakthroughs to solve these complex healthcare challenges. One, I'll be remiss if I don't thank the volunteers on behalf of the panelists, because it wouldn't be possible without them. And thanks to all of you all who attended this. Thank you, thank you, thank you. Have a great day, great evening, great night.